Our next speaker is Dr. Bronwyn Hamilton, Professor of Radiology at the Oregon Health and Sciences University. She will be speaking on the oropharynx.
Hi, I'm Bronwyn Hamilton from Oregon Health and Science University, and I'm going to be discussing oropharynx today. All right, in terms of an outline for the next 30 minutes, what we'll be discussing, we'll start with a review of terminology. We'll discuss some modality considerations. We'll review normal anatomy and some variants, and then we'll finish up with pathology and discuss cancer staging. In terms of terminology, so we're all on the same page, we want to remind ourselves that the oropharynx is comprised of the palatine and lingual tonsils. The palatine tonsils are synonymous with fascial tonsils. It's just a different term, same thing. The lingual tonsils are synonymous with the base of tongue. So we want to be sure that we understand that terminology. And note that the oropharyngeal structures of the palatine and lingual tonsils plus the adenoids in the nasopharynx make up what comprises the Waldeyr's lymphatic ring. But the adenoids are separate from the oropharynx. We don't want to confuse the oropharynx structures with the oral cavity structures, and the oral cavity is comprised of those really obvious structures on the physical exam that include the oral anterior 2/3 of the tongue, the gums, and the gingiva. In terms of modality considerations, I think most places use contrast-enhanced CT. This is the workhorse standard. It's fast and easy, less issues with secretions and so forth. Patients can tolerate it really well. Enhanced MR is really great for oropharynx because it has less metal and dental amalgam artifacts, so it can be really useful. It also has superior soft tissue contrast, and it's ideal for perineural tumor spread evaluation. However, a lot of patients can't always get MR, and I think as a general rule, the otolaryngologists are also more familiar with CT, and it's just easier for most patients. How does PET-CT factor in? Well, PET-CT is really helpful to look for an unknown primary, to do a directed search and guide biopsy. It's helpful for distant metastatic disease, and it's good perhaps for evaluating clinically silent nodes that may be small and non-palpable but show up as hypermetabolic. PET-CT is also helpful in the setting of recurrence, to look for recurrent disease, and often done at the 3-month time point post-therapy. But note that it's better for the HPV negative or P16 negative carcinomas, and early data suggests it may not work quite as well for HPV positive cancers, which can still be have some avidity at this time frame and may require later imaging. It seems to take longer for that avidity to go away. And I think we're just still early days with PET-MR, but may prove to be really helpful in terms of sort of the best of both worlds in some senses. What's the value of different imaging modalities? Well, this is just a case example. The patient who was initially imaged at our institution for throat pain. This study was called negative, and the finding is really hard to see. I think if we look at this carefully, we can appreciate there's some tonsillar fossa asymmetry. The left palatine tonsil is a little bit bigger, but I think if we were just imaging for throat pain, most of us, might kind of blow that off and ignore it. The patient came back because they had left glossopharyngeal neuralgia. This is a fairly specific symptom, and they underwent MR for this. Unfortunately, this scan was also called negative, but you can see that same asymmetry. And notice how MR really has that superior contrast resolution where the enhancing left asymmetric tonsil is much more obvious. Kind of asymmetry extending into the glossotonsillar sulcus. So this is much more suspicious, and I think, especially in the clinical context, is more worrisome. This turned out to be PET-avid, and you can see how nicely this shows up. There's no question here about the asymmetry, and this was biopsied in clinic and did turn out to be a P16 positive T1N1 squamous cell carcinoma of the tonsil. So just to note that history is really important. I think most of the time these squamous cell carcinomas will come in with a known history, but occasionally you'll find these ones that come in really with just a clinical finding or symptom. And I think if you have non-specific things like a sore throat or enlarging neck mass, well, neck mass is more helpful, but like a sore throat is not very specific. But I think if you have something that suggests the potential for cranial nerve involvement, such as glossopharyngeal neuralgia, otalgia, or trismus, you really want to look carefully and consider getting an MR if you don't see the cause. So moving on, let's talk a bit about oropharyngeal anatomy. So this graphic depicts the palatine or fascial tonsils, which are depicted by this asterisk here, and you can note they're between the anterior and posterior tonsillar pillars shown by the arrows. The lingual tonsil is really not imaged because it's behind the circumvallate papilla at the base of tongue, so we don't see it well on this particular graphic. But we can see it on this axial graphic, where the lingual tonsil is going to be that lumpy, bumpy tissue that's the posterior 1/3 of the tongue, or base of the tongue, that's posterior to and including the circumvallate papilla, which you can see on this graphic right here. The anterior pillar is comprised, the primary bulk of that is the palatopharyngeus muscle, which you can see on this axial graphic, and the posterior pillar is comprised of primarily the palatoglossal muscle under the mucosa. Note another structure is the superior pharyngeal constrictor muscle, depicted here. Now I've outlined it in white for you. So those are the relevant muscles in the oropharynx. And you can also see this pink line depicting the middle layer of deep cervical fascia, which was discussed, I think, well in earlier talks. In terms of the craniocaudal extent for the oropharynx, if you draw a line parallel to the hard palate, you can see this is the upper extent of the soft palate, which is included, and the inferior extent is going to be at the level of the vallecula right here, which is the inferior extent. On an axial scan, there's the superior extent and the inferior extent here. And on an axial scan, the superior margin of the hyoid can be used as a marker for the vallecula, which are these air-filled spaces here, or you can use the pharyngoepiglottic folds here, or the glossoepiglottic fold. In terms of anatomical relationships, this has been discussed in earlier talk. On the airway side, there's really no fascia at all, so there's nothing, stopping it there. And along the deep aspect of the oropharynx, defined by this pink layer that represents the middle layer of deep cervical fascia, does present a relative barrier to disease spread into the retropharyngeal space or parapharyngeal space. On this coronal graphic, again, the pink line shows that middle layer, and you can see the oropharynx depicted in blue, just kind of outlining that space. What are the contents of the oropharynx? Well, this is really going to predict some of the diseases that happen here. So we know that we have primarily stratified squamous epithelium, we've got lymphoid tissue, and minor salivary glands, and this is going to help predict what kind of tumors arise here. So based on this, the mucosa is primarily going to give rise to the most common tumor, squamous cell carcinoma, lymphoid tissue gives rise to lymphomas, and the minor salivary glands gives rise to a whole host of primary tumors. And just remembering, there's no division between the oropharyngeal mucosa, which is contiguous with the oral cavity anteriorly, the nasopharynx above, and the hypopharynx below, as well as the larynx below. So just remember that mucosa is contiguous. In terms of, for staging purposes, we think about the oropharynx in terms of 4 subsites, and those subsites will include the lingual tonsil or base of tongue, as we've talked about, the palatine tonsils, which are seen laterally, not shown well on this graphic, the posterior wall of hypopharynx back here, and the soft palate. The epiglottis itself, remember, is part of the larynx and not considered part of the oropharynx. Some normal variants to be aware of when we're looking at imaging include prominent lymphoid tissue, especially in younger patients. You can see on this axial T2-weighted scan, there's pretty bulky lingual tonsillar tissue. This can get quite full and fill the vallecula in young patients and young adults. If it is persistently enlarged in older patients and middle-aged adults, then we need to think about other processes. That can be due to infection or Epstein-Barr virus, or it can be due to lymphoma or even squamous cell carcinomas, especially when it's asymmetric, and so that's something we don't want to keep an eye on in older patients, but definitely normal in young. If a patient has prior tonsillectomy, that can cause some confusion, as in this case, where it was read as a right-sided palatine tonsillar mass, but you can see the normal morphology, the crypt-like morphology with those lines. This is just normal palatine tonsil on the right, and the patient had a prior left tonsillectomy. And there's just another example of lymphoid tissue on the sagittal. Let's transition and talk to you pathology. So one of the most common things we'll see, and primarily I'm going to focus on infections and neoplasms, since that's primarily what we're dealing with when it comes to imaging. So infectious etiologies are quite common. Tonsillitis is fairly common, and complications of that include tonsillar and peritonsillar abscesses. And of course, the important complication of retropharyngeal abscess and Lumiere syndrome, but in particular, retropharyngeal abscess requires surgical intervention, so important to recognize. let's show a few examples. So here's an axial and a coronal reformat CT. And this is the classic tiger stripes of tonsillitis, where you can see both the palatine tonsils are swollen and edematous with low attenuation. And you can see those kind of tiger stripes from the normal crypt-like morphology is preserved within these tonsils. So pus within the tonsils, but doesn't need surgical intervention. There's no spread into the parapharyngeal space, which looks nicely preserved with the fat there. And you can notice there's expected reactive adenopathy in this patient who has an obvious infection going on. Here's another case. This was a 48-year-old male who had type 2 diabetes, and this is basically all abscess within the tonsil. Again, hasn't ruptured at this point. Again, you can appreciate on the coronal the beautiful crypt-like architecture with these kind of indentations and this linear appearance, which is that tiger stripes kind of right greater than left. Interesting story about this patient is he was in the ICU. You can appreciate how he had airway compromised and was suctioning secretions himself and managed to self-decompress the pus, which drained into his throat when he punctured it accidentally with the suction device. So he did not need surgery. Here's a young patient, a pediatric patient who is 13 months old, who has a peritonsillar abscess. Now you can appreciate the loss of the crypt-like morphology. This is kind of spread laterally into that parapharyngeal space. It's causing some mass effect on the airway, but it's lost that kind of normal architecture and now appears like it's ruptured out laterally. So this is a peritonsillar abscess. An important complication of pharyngeal infections, but also retropharyngeal adenitis, as in this case, is this young patient with a retropharyngeal abscess. You can appreciate this is in front of the longus colli muscles, but behind that density of the pharynx. This is in the retropharyngeal space, nicely seen on sagittal images, and when we see this, we know we have to alert the surgeons that this patient needs a drainage procedure. Lemierre's syndrome is pretty uncommon, but it is a delayed complication after an upper respiratory infection and often a tonsillitis, where you can develop this post-infectious venous thrombophlebitis and septic emboli. Now, there's a lot of variations on the theme for Lemierre's, but most often you'll see either facial vein thrombosis, or you can see a complete or partial occlusion of the right internal jugular vein, as in this case here, due to thrombosis. And you can appreciate the stranding in the adjacent neck. And then we want to look down in the chest and abdomen for septic thrombotic complications, and most often these are going to be in the lungs in the form of pulmonary emboli, but the liver and the bones and other structures can be involved, and again, there's many variations on this. The usual causative agent is that Fusobacterium necrophorum. I'm going to spend the rest of the time talking about neoplastic etiologies. In particular, we want to talk about HPV positivity and how it relates to staging. Then we'll spend a little bit of time on the other two primary malignancies of the oropharynx, which include lymphomas and minor salivary gland tumors, which there are both benign and malignant varieties. You're probably all aware of the AJCC 8th edition changes that did have a strong impact on oropharyngeal cancer staging. There's a new stage classification specifically for HPV positive cancers. This now comprises the majority of oropharyngeal squamous cell carcinoma, up to about 70%. And this is based on the P16 immunohistochemistry, which is the best surrogate we have for HPV positive cancers. We separate the staging into clinical and pathologic designations. For the end staging, and new T and N groupings were introduced. And note that the nodal status is quite a significant change from the 7th edition, so we're going to spend a little bit of time on that. So we'll start with P16 positive cancers. These are our HPV cancers first. So in terms of T staging, this is not a big change, but in effect, no tumor T0. T1 cancers are going to be less than or equal to 2 centimeters, T2, 2 to 4 centimeters, T3 over 4 centimeters, or it can involve the lingual surface of epiglottis. That doesn't constitute laryngeal invasion. And then there's a kind of a checklist for moderately advanced disease. So there's no more T4A and T4B with P16 positive cancers. There's just a T4 category. And basically, the things that constitute this invade a number of structures that are regionally adjacent to the oropharynx. So I have a couple ways to remember this. One is by the direction of invasion, and if you're a person who likes mnemonics, this is a mnemonic I came up with called Help Me, for hard palate, extrinsic tongue muscles, larynx, the pterygoid muscle, the medial pterygoid muscle, and the mandible or beyond. If you're a person who likes to think about things in terms of what makes sense, I think most of us like that. I try to just remember the structures that are nearby. And so if you have an oropharyngeal primary, if it goes anterior, it's going to spread to the oral cavity structures. If it spreads, there you go. If it spreads inferiorly, it's going to go to the larynx. And if it spreads above, it's going to go to the skull base. And of course, if it spreads laterally, it goes into the masticator space and the mandible. So that may help you remember those critical structures that upstage the tumor to a T4 lesion. The end staging for P16 positive cancers is very different than P16 negative. And this reflects the fact that these patients just biologically have less aggressive disease. So you're allowed to have more nodes, and they're going to have a better prognosis, particularly if you look at the pathologic staging. But we're going to spend time primarily on the clinical or C stage. So the CN1 will include ipsilateral nodes that can be multiple, but none greater than 6 centimeters. The CN2 stage is any contralateral or bilateral nodes as long as they aren't over 6 centimeters, and CN3 is over 6 centimeters. So you want to remember that number, 6 centimeters. In terms of the stage groupings, the overall stage is strongly impacted by the end stage for P16 negative cancers. But for P16 positive, you can have N0 or N1 disease, and it can still be stage 1 unless the T stage is higher. And N2 disease is only stage 2. This is a big deal because previously this would have been stage 4 disease with a P16 negative cancer. And I'll show you the comparison of those staging groups later. Here you can appreciate the P16 negative. This is stages, N0 comprises the stages 1 and 2, but N1 would have been stage 3 disease and N2 is stage 4, and that's still how it is for P16 negative. So you can appreciate the big impact that the end stage has with respect to P16. P16 negative oropharynx and hypopharynx cancers, in the AJC 8th edition, there's no T0 category. And also they've incorporated extranodal extension formally into the nodal staging, and this has a very profound impact on prognosis, and that's why it was included. So the T stage will look very familiar to you, with the exception that instead of the T0, we call it TX for no primary identified for the unknown primary. There is an in situ carcinoma category, but then the standard T1 through T3 is basically identical to the P16 positive cancer staging, but T4 does get subdivided into T4A and T4B, and the T4A will look very familiar. You've got your help me list like before, and T4B is just going to be the and beyond category, which is skull base, carotid, lateral pterygoid, nasopharynx or pterygoid plates. I gave you another mnemonic if you like that, scalp, just to remember those structures. The P16 negative nodal staging, the clinical nodal staging includes N1 is only one ipsilateral node less than or equal to 3 centimeters. So you only need one of those nodes for N1 disease. N2 disease, you have this all and can read this, but N2A is 1 greater than 3 but less than or equal to 6. These are all extranodal extension negative. 2B is multiple ipsilateral less than 6. 2C multiple bilateral or contralateral less than 6. And then the N3 is either nodal metastasis over 6 centimeters, extranodal extension negative, or any node that's extranodal extension positive is an N3B. So if you just look at this chart, the old staging, the P16 negative, you can see how the T staging is tied very closely to the stage grouping. So T1, stage 1, T2, stage 2, T3, stage 3, and so forth. But the nodal staging has a strong impact on the overall stage grouping. So as soon as you have N1 disease, you're stage 3. And if you're N2 disease, you're automatically stage 4, regardless of the T stage. But notice how different this is for P16 positive cancers. Now, you can have variable T stage up to T2, and the N0 and N1s are still stage 1. But N2 disease, which for this category would be stage 4, this is only stage 2 disease for the smaller tumor types. So we can appreciate how, because of the staging system, the vast majority of P16 positive cancers end up getting staged as a early stage cancer, stage 1, whereas the majority of P16 negative cancers are high stage tumors. So it had a big impact. Just to show some examples of how this works, this is P16 positive tonsil squamous cell carcinoma. You can appreciate the tonsil primary here. And there's a couple of ipsilateral nodes, so 2 ipsilateral nodes means N1 disease. This is stage 1 for P16 positive cancer. But those 2 nodes would have been stage 4 disease based on the presence of N2 disease if it were P16 negative. This case here, you can't see the primary very well, but the nodal necrosis is very obvious, and you can appreciate the primary better with PET here. And even though that's a necrotic node, it did show up on PET. This one's T1N1, stage 1 disease for P16 positive. Notice that that single node would have made this stage 3 disease if it were a traditional P16 negative. This is pretty gross extranodal or extracapsular extension. It looks like it's invading into the sternocleidomastoid muscle. This is the finding that we really want to remark upon, so the pathologist looks carefully for it at tumor board, but clinically overt E&E is N3 disease and stage 4 for P16 negative cancers. P16 positive cancer, notice there is no category for extranodal extension. So technically, this is really could still be stage, this could be N1 disease and would be staged depending on the T stage. So it could be relatively low stage even with that extranodal extension. I think there's some early data suggesting that this is also a harbinger of a worse prognosis in patients with P16 positive cancers, but they clearly just have a better prognosis even despite the presence of E&E in HPV cancers. This patient had a T3 tumor that was a little bit over 4 centimeters. You can appreciate on the CT scan that there's some involvement of the extrinsic muscles that would upstage this to a T4, even though clinically it was a T3. So this is a case where imaging actually made a difference. And there are bilateral cervical lymph nodes that are under 6 centimeters, so that makes this an N2C. For P16 positive cancer, this would be staged as a 2 clinically, but we can upstage this to a stage 3 because of that T4 involvement on CT with the extrinsic muscles, and this obviously would have been a higher stage if it was P16 negative. And here's just a better view of that extrinsic muscle involvement on the sagittal reconstruction. This patient here has some subtle asymmetry in the right base of tongue, but note there's some effacement of the adjacent flat planes next to the pterygoid muscle. This patient, I think, had renal failure or some issue where they couldn't get contrast, so it's hard to appreciate that this T4 squamous cell carcinoma was invading the adjacent structures. They did get a follow-up MR where now you can really appreciate the low signal on T1 in the mandible and the enhancement that makes this a T4 squamous cell carcinoma of the oropharynx. How do I report these cases? So it's a good question. I think staging specifics are a little bit less important. And you know that radiologic staging reports can be controversial with a lot of people. But I think the really key element here is to provide the staging elements in your report, the things that allow them to stage things. So the T stage, we really want to document the tumor size and the presence of any invasion of those critical structures we talked about. The end stage, you should really measure the node number, the location, and the size. And certainly note if there's extranodal extension, because we don't always know if they're P16 positive or negative, and it may be more important in the future when they revise staging for P16 positive in the future. The M stage is important for distant metastases, so if I'm just looking at the next CT, I'll take a look at the lung apices and the bones, and of course if you have a PET, that's very helpful. And then if you still have questions, it's helpful to have that copy. We have a copy in a box folder that all the residents and fellows have access to of the staging manual, which is super helpful. Let's talk about the last couple cancers that we'll review today. Non-Hodgkin's lymphoma. typically has a large and bland appearance. So you can have very bulky adenopathy and primary disease, but it's characteristically non-necrotic, unlike squamous cell carcinoma. So often you can prospectively call this a lymphoma simply because of that fact. It's not very enhancing and there's no necrosis. The clinical clues to lymphoma are that the mass itself is submucosal on exam, so there's no ulcer or obvious mucosal lesion when the clinician looks in there. And the radiologic clues are the fact that they're quite bulky without necrosis, and another radiologic clue is very high PET avidity with lymphoma, which tends to be higher than that of squam. Note that there's a different staging system that I won't go over this today. So primary and mass, nodal mass. Let's talk a little bit about minor salivary gland neoplasms, which is the other major category and the least common. This will include the clinical clue, again, of often a submucosal mass on clinical exam. Frequently, when these are more benign or are carcinoma XPA, we'll have a long-standing history of a palpable or a mass that the patient is aware of. The radiology that's relevant includes the fact that benign lesions like the more common pleomorphic adenoma can have a very typical appearance. It can be very well circumscribed with a round nodule. And if you do an MR, that marked T2 hyperintensity is very characteristic for PAs, and you won't see that with squams. But of course, a malignant neoplasm is really going to mimic a squam, and you won't be able to separate those prospectively. It turns out these are staged like squamous cell carcinoma anyway. Here's a nice pleomorphic adenoma example. Looks like a round little nugget in the soft palate. Pretty T2 bright, not quite as bright as CSF, but did turn out to be a benign pleomorphic adenoma. These two were two different patients with two malignant salivary gland malignancies. On the left side, we have a mucoepidermoid carcinoma of the right tonsil with a focal calcification. And on the right side of the screen, you'll see a mucoepidermoid carcinoma of the soft palate. No way to know that wasn't just a benign tumor or a squamous cell carcinoma, really. Adenoid cystic carcinoma, if you see these, of course, you want to be very careful that you look for perineural tumor spread because these have a very high predilection of spreading along nerves. This is the very small primary in this case, but had extensive perineural involvement, including orbital apex and V2 rotundum involvement in this case. There you can appreciate expansion of the pterygopalatine fossa compared to the normal side due to V2 perineural tumor spread. So in summary, we've talked about oropharynx anatomy, we discussed a bit about imaging modalities and their relative strengths and weaknesses, and then we talked about the primary pathologic entities, including infection and tumor, and talked quite a bit about HPV versus HPV negative cancers and how this impacts staging. And my last suggestions to you are, if you have that opportunity, I always try to recommend people attend tumor board and talk to your clinicians. They have a lot to teach you. Thanks very much for your attention. Any questions, please don't hesitate to email me. And have a good day.
Our next speaker is Dr. Christine Glastonbury, who is a professor of clinical radiology and biomedical imaging. Sorry, she has many titles, but she is not an engineer. She will be speaking on the oral cavity. She serves as the Vice Chair of Academic Affairs at the University of California in San Francisco, as well as the Interim Section Chief of Neuroradiology. She also serves as the ASHNR Education Committee Chair, and as mentioned, she will be speaking on the oral cavity.
Hello, I'm Christine Glastonbury, and I'm delighted to be sharing a new lecture with you today about the oral cavity. I have one disclosure. So this is going to be not the typical lecture that I would normally give. I want to give a kind of up close and personal interactive lecture since we don't all get to be up close and personal this year for ASHNR. And we're going to talk about going inside the oral cavity. And I hope you've got your props with you that I tweeted out that you would need for this lecture. So the couple of things that I really want to make a point about with this lecture over the next 20 minutes is really that the oral cavity really has complex mucosal surfaces. It can be really difficult to image this area well, But really, it can be pretty difficult to interpret this area well. And I want to share some of the cases and some of the things I've learned about why I think people miss the primary on these scans and why we don't do so well sometimes with imaging. It's really important to be aware that staging requires pathology. And I want to make you very aware that you've got to be very careful with squamous cell carcinoma nodes from the oral cavity. They can be tiny, they can hide, and they can skip. So let's start with the anatomy and understanding how the oral cavity works. And we're not really going to talk about the jaw bones because we think of the mandible and maxilla as really part of the masticator space, even though they're pretty critical to the oral cavity, and we're going to pay a lot of attention to them when we're doing oral cavity imaging for tumors. The tongue is kind of what everybody spends all their time talking about, and how do I distinguish that from the flora mouth? And we're going to talk about that. But I really want to start with talking about where I think people make the most mistakes and I see the biggest problems, and that's really the mucosal surfaces. And I really think it's important that we spend some time here. So I hope you brought your glass of water or your glass of whatever keeps you happy while you're sitting watching lectures online instead of being in a meeting. And we're going to start looking at the oral cavity. So a CT and an MR, and it's pretty clear on CT, if you have the same experience that I do, that dental amalgam is not your friend. This kind of spray artifact really makes oral cavity imaging pretty difficult. And I think this is probably what most people think is the #1 problem with oral cavity imaging, but really it's not the #1 problem with oral cavity imaging in my experience. And at this point is where I want you to take your first drink in our interactive lecture. So take a big swig of something. Don't swallow it. Don't swallow it. And I want you to swish it around inside your mouth. And as you're swishing it around, I want you to think about those mucosal surfaces that water or whatever you choose to be drinking is touching. And it's understanding these mucosal surfaces, and specifically the gingival surface, the floor of the mouth, the buccal mucosa, that I think is difficult for people to understand when they're looking at their CT or their MR imaging. You know, sometimes you're lucky because somebody happens to leave something behind when they get in the scanner, and, you know, a bit of candy or a bit of chewing gum, and you can start to see the buccinator muscle being pushed away, kind of blowing out the cheek, and people remember, oh yeah, when I'm looking at the mouth and someone has their mouth closed, there are actually two opposed mucosal surfaces here. And sometimes you're super lucky and your patient comes in, your head and neck patient comes in with a wad of chewing tobacco in their cheek, which they can then kindly take out so that you continue your imaging for them. But Jane Wiseman came out with this really beautiful technique that she published in AJNR quite a number of years ago, and that's the puffed cheek technique. And I don't do this a lot when I'm imaging, but I think it's a really good way for people to really understand these mucosal surfaces. And when you distend your cheeks with air or that swig of drink, that yes, you can take another swig of your drink right now, take another whole mouthful, you can start to really appreciate the mucosal surfaces. And this really helps you when you're looking at a patient who does not have their cheeks distended. Now, we did a study. This is somebody doing their MR. This is pre-distension and with distension. And you can do this with distending with air. We also did a nice paper looking at people distending it with gauze, which actually ends up looking the same intensity on MR as air. And if you look at the teeth here, we're almost at exactly the same level. And you cannot see this buccal mucosal squamous cell carcinoma at all when the cheek is relaxed. And so, you know, when they tell you there's a buccal squamous cell, no wonder you can't see it on your MR, and you feel like a little bit of an idiot reading these scans sometimes because it's very difficult to see small lesions, beautifully demonstrated here, and you can see the entire extent of it with the air distended. When we look at the puff cheek, let's look at some of those anatomical landmarks. And so the buccal mucosa is that mucosa lining the buccinator muscle. Buccal is just Latin for cheek, but you can see as you distend out and you really thin out the buccinator muscle, you can see here it inserting down onto the alveolar portion of the mandible and onto the alveolar portion of the maxilla. And we have this gingiva. So the gingiva lines the alveolar portion here. And then we have superiorly and inferiorly, we have the gingivo-buccal sulcus. And that's where the gingiva of the maxilla and the mandible are continuous with the mucosal lining of the buccinator muscle or the buccal mucosa. So when patients come in, and this is a gentleman with a left buccal squamous cell carcinoma, and we can see here that we have the enhancing tumor, beautifully seen on the coronal plane. And honestly, for oral cavity imaging, you really want to have coronal reformatted images or coronal plane MR images to help you with your imaging. But you can see this lesion. Now, while it is arising from the buccal mucosa, it's going to extend laterally. It will also extend down, in this case, down to the insertion of the buccinator muscle onto the mandible. And it can also extend upwards, although it does not in this case, and this was a buccal which was completely excised, because surgical excision is the mainstay of all oral cavity tumors. This is another patient, this is another patient, and you can see presenting with a left cheek mass, and you can see the asymmetry quite readily when you compare it here to the normal side. In this case, you can see the buccinator muscle, which will insert on the orbicularis ori muscles, but you can see here this marked fullness, and without a distended cheek, it's kind of, people get a little confused sometimes in understanding exactly where this is. But this is not going to invade the bone here. Where it will invade the bone is when it comes down the buccinator and where the buccinator actually inserts onto the mandible itself. In this case, it started down low and was growing up along the buccal surface. This patient had a couple of nodes. This is 1B nodes, a really typical site of metastatic nodal disease, and there was extranodal extension, which is critical for staging of oral cavity tumors. So buccal squamous cell carcinoma is buccal tumors are those arising from the mucosa which lines the buccinator muscle, which of course is spanning the maxilla and mandible. So when these tumors happen, you want to make sure you look northwards and southwards to the gingivobuccal sulcus and see if it involves the gingiva and if it involves the alveolar portion. So you're going to need your bone windows here. Tumors otherwise are going to spread laterally out into the soft tissues of the face. Okay, so let's look from the buccal mucosa and come back in this beautiful puff cheek back to this area behind that. That's the retromolar triangle. So this is when I hope you brought your finger with you, which I know you have, because now you're going to stick your finger into the back of your mouth, go behind your third mandibular molar, if you still have your third mandibular molar there, and feel that space behind the molar. That's the retromolar trigone. That mucosa, which is lying over the bone here, is retromolar triangle mucosa, from where RMT tumors arise. So these are really interesting tumors because I think these can grow extraordinarily large before people can see them on imaging, and it's a great place if you ever want to hide a tumor on a head and neck scan. You put it in the retromolar trigone. It's very easy to hide them here. So this is a patient who has an RMT tumor, and I've told you they have one, so I'm hoping that you believe me. But this is insanely subtle, even with a pretty decent contrast enhanced study here. But you can see this very subtle asymmetry of fat. So when you get a request form that says oral cavity tumor or oral squamous cell carcinoma, you can be forgiven for not seeing this subtle asymmetry. And then, of course, you have the benefit of fabulous amalgam, once again, making life really difficult. And it's no wonder that these tumors are readily missed. But as we go northwards, and this is one of the things to think about with RMT tumors, they have a tendency to grow northwards as well as anteriorly and medially. It is growing upwards. But notice this interesting feature. It grows northwards along the pterygomandibular raphe, which is the insertion site of this buccinator muscle. So it actually will grow upwards along the pterygomandibular raphe, and then it can grow outwards along the buccinator muscle, as well as wanting to grow medially towards the paladoglossus. This is our paladoglossus, which is our anterior tonsillar pillar, and of course the tonsil immediately posterior to it. But as it comes back this way, it's going to start just effacing the fat planes. These are very subtle sometimes, very, very easy to miss. Here's another patient with a left retromolar trigone. Again, amalgam is not our friend in the oral cavity. It is filling this space, and you can see how easy it is to miss it. On the coronal, you can see it growing upwards towards the maxilla, and it's traveling up. Here's the normal for comparison. It's traveling up that pterygomandibular raphe. The other feature to look at is if we come up a little higher, it's grown all the way up. Here we are up at the maxilla. It's growing out along that buccinator. But look at the complete loss of that Behçet's fat pad. We have this beautiful area of fat, and it's completely gone. Really, really subtle sort of tumor if you're running quickly through your scans. But once you start looking for normal fat planes around muscles such as the masseter and the pterygoids, you can see how this tumor can hide. A little higher, you can see it growing out along the buccinator. So RMT lesions are pretty nasty for resection. They can get pretty sizable and require quite sizable resections while hiding on a scan. And I've seen many scans when these are called normal. And a lot of the time, I think it's because the clinician didn't say where the tumor was. Once you know it's an RMT, it's kind of easy to find these lesions. Remember, stick your finger back behind your teeth and you can find those. They have a tendency to grow down into the bone, so definitely looking at bone windows here. They're going to grow medially and laterally, anteriorly along that buccinator back towards the oropharynx. And also remember, they grow up or down if it starts behind in the maxilla along that pterygomandibular raphe. So let's move on to our next gingival surface. And if we go back looking at our gingivobuccal sulcus, and we have maxillary gingiva here. And here's a patient who left their dentures in quite nicely for us. So you can see here alveolar portion of the maxilla. And this dark line here is where the gingiva is. And then, of course, the dentures are on top of that. So this is our maxillary gingiva. And if you look in the coronal plane, here is our maxillary gingiva internal to the oral cavity, and it is continuous with the palatal mucosa, which is lining the undersurface, remember, of the hard palate. And in most patients, the tongue will sit up against it in your scan, and people kind of aren't really thinking there's actually an air gap here for obvious reasons. Yes, I want you now to stick your finger in there, and you can feel the roof of your mouth and see how the alveolar portion of the maxilla, which has mucosa over it, so that's maxillary gingiva, is continuous with the palatal mucosa. In the sagittal plane, you can see it coming back posteriorly as well. So this is a patient with a left palatal mass, and on the coronal and sagittal, you can see this very neat and tidy, mildly enhancing lesion. And I will tell you that coronal is my very, very favorite plane when I have palatal lesions, whether it's CT or MR. I think this is really critical. Most of these palatal lesions, you can get squamous cell carcinoma, certainly, of the hard palate, but most of the hard palate lesions are actually minor salivary gland tumors, and they often look submucosal to the clinician. This same lesion on the coronal, you can actually see the fat submucosal fat over the top of this lesion, which is not invading into the bone. Yes, you need to have bone windows to look at this. This is a little more unfortunate case of a much larger lesion, and you can see it looks like it's growing up here into that right maxillary sinus. This was actually a low-grade neoplasm. It was not resected because this patient had many other malignancy, other problems that couldn't be taken care of. But I want to show you this to you again because the coronal plane is really, really helpful when looking at the extent of this lesion, looking for invasion into the palate. Is it just expanding the bone? Is it thinning the bone? Is it destroying the bone and going into the maxilla? And is it going up the greater palatine canal, which of course is a branch, carries a branch, the second division of the trigeminal nerve, which comes from the pterygopalatine fossa down the greater palatine canal to supply the palate. So a reminder that most hard palate masses are minor salivary gland, and the coronal plane is really, really helpful to see if it is growing into the palate, and multiple planes are obviously helpful, but you've got to think about perineural tumor along that greater palatine canal to the pterygopalatine fossa. So let's look down now at the mandibular gingiva. So again, we have that laterally, which is continuous with the gingivobuccal sulcus, and then we have it internally. And on our axial plane here is our mandibular gingiva lining, and there's a squamous cell carcinoma there. And if you told me, I don't believe you, well, I get that, but I can tell you honestly, there is a squamous cell carcinoma. And once again, look how incredibly easy it is to miss these tumors, and the clinician knows they're there, and they're very easy to see on clinical exam, and you kind of do feel like a little bit of an idiot. But this is a very subtly enhancing lesion that is actually arising from the mandibular gingiva, from the gingiva here overlying the alveolar portion of the mandible. And again, you've got to look at bone windows, and you can see this very, very subtle cortical erosion, and it's growing into, as it erodes the cortex there, it's growing into the tooth socket, which is part of the description you want to put in there, because it is a difference for staging if it's growing into the mandible, down the socket, versus just growing straight into the marrow content itself. So you need history, not mystery, when you're reading some of these tumors, because they can hide very readily on these scans. And again, you do feel like an idiot when you miss something that turns out to be a T3. But you need to have bone algorithm when you're looking at gingival squamous cell carcinomas. You want to look for cortical erosion and marrow infiltration. Okay, now we're going to get into the oral cavity proper big time here. So the oral tongue is that bit that's loose. This is kind of critical. And the floor of the mouth is that bit internal to that mandibular gingiva that we were talking about. And it is actually continuous with that, the mucosa over the floor of the mouth. And yes, you know what I'm going to tell you. This is when you get your finger out and you take a look in, or even better, I hope you have your cell phone with you. You can put your photo, take a look at yourself, take a selfie. You can send it to me later, and lift up your tongue and take a look at the floor of the mouth. And this is where tumors lie. Now, of course, when you image people, the tongue is folded down. So again, the mucosal surfaces appear opposed to each other. But we really need to feel really confident that we understand some of these anatomical landmarks. So let's go through these critical landmarks. So let's come back to here. We're in the body of the tongue. So these are the intrinsic muscles of the tongue here in the bulk of the body of the tongue. We're going to come down a little lower into the floor of the mouth. Our mylohyoid, the levator ani of the oral cavity holding everything else up, is the smiley face in the coronal, and it has this funny kind of appearance laterally when you're looking at an axial image. Our sublingual gland is anteriorly. So then we have immediately above that our paired geniohyoid muscles. Above that, the genioglossus. This is the big one. This is the bulk that's going to come in as one of the tongue muscles, and it is really a big one, but paired with that nice little fat strip between the two genioglossus muscles. And then we have this kind of semi-lunar muscle adjacent to it, and that's the hyoglossus. And the hyoglossus is a really good landmark to get used to, because medial to the hyoglossus is the lingual artery with the glossopharyngeal nerve, and lateral to it is the lingual vein and the lingual nerve, which of course is a third division of the fifth cranial nerve, and the 12th nerve, the hypoglossal nerve, which is supplying the tongue, and then the submandibular gland duct. Wharton's duct is traveling lateral to that hyoglossus muscle. So let's look at a patient with a floor of mouth squamous cell carcinoma. We have T2 and T1, and we have all our nice landmarks, but they're nicely covering up for the tumor here. So you can see here's the hyoglossus, and this tumor of the left floor of the mouth is coming into the hyoglossus muscle here, coming just to the margin of the genioglossus muscle there. But remember, lateral to hyoglossus is our submandibular duct, and you can see on the T2 that duct here is being obstructed by this tumor. And of course, there's the mylohyoid muscle lateral to it. So oral tongue tumors generally tend to arise from the lateral aspect and the undersurface of the oral tongue. And what you're looking for in imaging is this deep invasion down to the floor of mouth. But of course, the floor of mouth is covered with mucosa, and squamous cell carcinomas can arise directly from there. Once you're in the floor of the mouth, you've got to look very carefully at the bones, because it's going to invade the bones. That's what they like to do. And, so you need bone algorithm. And this is a floor of mouth that, this one invaded the bone. Obviously, T4 is bone invasion. This is what I think Dr. Wiggins would call a T5 tumor. So I just want to finish with some oral cavity cancer staging top tips here. This was our AJCC7, and it changed big time with the 8th edition by introducing some new information, and particularly this, DOI. And you really need to know what DOI is, not for your staging, because it has nothing to do with you staging anything, but you need to know because this is going to come up in tumor boards, because this is where your pathologist is critical to you. So DOI is really just dropping a plumb line. It's the depth of invasion or the depth below the basement membrane that a tumor is growing. It's not how thick your tumor is on imaging. It is how deep it is growing below the basement membrane, and they literally do a horizontal line and then a plumb line down. So tumor thickness is a different measure. And if you have an exophytic heaped up tumor, it's going to overestimate your DOI. And if you have an ulcerative endophytic tumor, then measuring the thickness is going to underestimate the DOI. But regardless, DOI is a pathologic measurement. So how is that going to change things? Well, this is a woman with a right lateral tongue squamous cell. It's not a very big tumor. We can see it quite nicely on the T2. It enhances nicely on the coronal. It is not doing deep invasion medially. It's not crossing, so it's not a big tumor. It looks like a nice small lesion we measured on our imaging as 1.58. So this is going to be under 2 centimeters. So we're thinking this is a T1 and it looked N0 in imaging. This was resected, 1.6 centimeters, negative nodes. All good, nice correlation here with my measurements here, makes me happy. The DOI comes out to 6 millimeters. So this now puts her up into this, which is T2N0 with a DOI of 6 millimeters. So really important, the pathologist is critical here. So what counts for the radiologist? And this is what you need to kind of pay a little attention to. Take another drink if you need it before this. So this is treated, this is surgical disease. So you need to describe the full extent of tumor. What Deb Schutzkes usually describes beautifully is tumor mapping. You need to describe exactly where this is invading and pull this out if it helps you. You need to know whether it's bilateral, unilateral, deep invasion, if it's going into other tissues or around other tissues. The other thing to be aware of is nodes are often small. There is a tendency for skip metastases, which is when a tumor goes from level 2 to level 4 and bypasses level 3. I don't know why oral tongue tumors do that, but they like to do that. And extranodal extension is really critical for staging. Obviously, this is a clinical finding or a pathological finding. And remember, this is surgical disease, so they will have their nodes resected. And with that, I want to thank you very much for your attention for this. And I would like to remind you that if you use this QR code, you can get straight to the AJCC8 for all your staging needs. And thank you. I look forward to hearing some of your questions.
Our next speaker is Dr. Hilda Stambuk, Clinical Head of Head and Neck Imaging and attending radiologist at the Memorial Sloan Kettering Cancer Center, as well as Professor of Clinical Radiology at the Weill Cornell Medical College, and she will be speaking on the larynx.
So I wanted to thank the ASHNR Organizing Committee and particularly Ilona for inviting me to speak today on larynx, anatomy, and pathology. In this talk, I'm going to review the normal anatomy of the larynx and its radiographic correlates. I'm going to then talk about the principles of imaging, focusing primarily on CT and MRI, and then we'll talk a little bit about PET. And then I'm going to spend the majority of this lecture going over patterns of tumor spread in the larynx. So as in all imaging, it's very important to know your normal anatomy. But for the larynx, I really wanted to emphasize mucosal anatomy first. And that's the mucosal anatomy is the anatomy that's seen by the clinician when they do direct or indirect laryngoscopy. And remember that the mucosal or the superficial disease is far better seen on direct clinical examination than on imaging. So how are these pictures obtained? Well, the surgeon is in the OR doing a direct laryngoscopy. They stand at the head of the patient and then they drop the scope into the larynx. Remember that the right side of the patient is a radiographic left and the left side of the patient is a radiographic right. Here's anterior and posterior orientation. Remember this when you're looking at these pictures. But when you do a direct laryngoscopy, notice that the focal point of the examination is the glottic larynx, the true vocal cord. So to review, the three subsites of the larynx are the supraglottic larynx that runs basically from the tip of the epiglottis to the upper half of the laryngeal ventricle. And then you have the glottic larynx that runs from the inferior half of the laryngeal ventricle for a whole centimeter and includes the true vocal cords. Below the glottic larynx, you have the subglottis that terminates along the inferior border of the cricoid cartilage. It's important to look at the adjacent anatomy that's not part of the larynx because it plays a role in tumor spread. So here's your epiglottis, here's your AE folds. The ventral surface of the epiglottis is not part of the larynx, only the dorsal aspect. So ventral to the, or anterior to the epiglottis is the vallecula, and anterior and superior to that is the base of tongue. You have the soft tissue that goes from the pharyngeal wall to the epiglottis. the pharyngoepiglottic fold that acts as a vehicle for or a route for tumor spread. And more cephalad, you can see the palatine tonsil. So the supraglottic larynx is made of the dorsal surface of the epiglottis, or the laryngeal surface, as well as the areoepiglottic folds. There are two, the paired false vocal folds and the paired upper half of the laryngeal ventricle. As you advance the scope, you can see better the false vocal folds. You can see the laryngeal ventricle mucosa. It's beautiful. And here in the glottic larynx, you can see the true chords as they come together to the anterior commissure. Posterior commissure is not included on this picture, but notice you can see the mucosa of the glottic larynx, subglottic larynx, and even the trachea. So really the clinician doesn't need us for the mucosal disease, they need us for deep extension, the things that they can't see. So let's build larynx. This is a posterior three-quarter view of the larynx. What I wanted to remind you is that the cricoid cartilage here is the foundation of the larynx. And why is that? Because if you remember, it's the only complete ring, and therefore it maintains airway patency for the larynx. It provides articulation for the arytenoid cartilages on its high back, and it also provides articulation for the thyroid cartilages. Notice when you axially image the larynx, you'll see the high back of the cricoid cartilage before you'll see the anterior portion and therefore the complete ring. The thyroid cartilage is a shield-shaped structure that encases the supraglottic and the glottic larynx. It also provides attachment for the vocal ligament, and it also provides articulation with the cricoid cartilage via the cricothyroid joint. Of course, the epiglottis protects the airway. It attaches to the thyroid cartilage via the thyroepiglottic ligament. And this is the anterior portion of the larynx. This is posterior. Remember that the back of the cartilage is very high, the cricoid cartilage, and on the high back are the paired arytenoid cartilages. Again, when you're imaging, you'll see the arytenoid cartilages in the supraglottic as well as the glottic larynx. And remember that the vocal process is where the vocal ligament attaches. So the membranes and spaces. If you look at this posterior three-quarter view of the larynx and you cut away the thyroid cartilage, you'll see two main membranes, a quadrangular membrane and the conus elasticus. The quadrangular membrane has no barrier to tumor spread, so I'm really not going to speak much more about it. But what's super important, this very important membrane, is the conus elasticus. So I just cut the larynx in half, and I'm letting you look at the opposite side. The conus elasticus attaches along the vocal ligament, so the medial surface of the cord, and the inner surface of the cricoid cartilage. So if you look at this coronal whole organ section of the larynx, you can see the laryngeal ventricle, and you can see the true vocal cord, the glottic larynx, and along the medial surface of the true vocal fold, you'll see this thickened pink area. This is the conus elasticus, and it attaches to the medial or the inner surface of the cricoid cartilages. What tumor goes from the mucosal surface of the larynx and goes deep, the conus elasticus stops the tumor from going back to the mucosal surfaces, but rather directs the tumor laterally and away from visualization on endoscopy. So this is really important barrier to tumor spread, and we have to be aware of it and dictate deep spread of tumors as a result of this. So the laryngeal spaces are formed by the membranes and enclosed by the cartilages. We have two very important spaces. You've got the pre-epiglottic space and the paired paraglottic space. The pre-epiglottic space it's a C-shaped space. It's enclosed anteriorly by the hyoid bone and posteriorly by the epiglottic cartilage, and then you have this thyroid membrane that wraps around its lateral border. This is a sagittal depiction of the larynx cut in half. You can see here's the pre-epiglottic space. Its roof is the vallecula. This is the epiglottis. You have a suprahyoid portion, but the infrahyoid portion makes the floor of the pre-epiglottic space. There's a very important ligament underneath the vallecula called the hyoepiglottic ligament, and this is a very important ligament for stopping tumor spread, which I'll show you examples. Notice that the majority of the pre-epiglottic space is made up of fat, so that's easy for us on CT. It should be black if it's not infiltrated by tumor, and it should be white on pre-contrast T1 MRI, and if it's not, if it's gray, then you know there's tumor infiltration. Then you have the paired paraglottic spaces, and basically this is the space deep to the quadrangular membrane, so it's submucosal, deep to the mucosa of the membrane, goes to the thyroid cartilage. If you look in the supraglottic larynx, it's primarily made up of fat. If you look in the glottic larynx, you can see that it's made up of the lateral half of the thyroid muscle and a little bit of fat. Now, if you have tumor that goes into the paraglottic space, say in the supraglottic larynx, it can go inferiorly into the glottic larynx or subglottic larynx and so on, and not be seen on endoscopy because it doesn't come to the mucosal surface. And note that these paraglottic spaces actually blend anteriorly into the pre-epiglottic space, so you can have tumor going all around the larynx and not being detected on endoscopy. So the only important muscle to me as an imager for the larynx is the thyroid muscle. It's an obliquely oriented muscle that runs from the vocal process of the arytenoid cartilage, and it attaches to in the anterior commissure at the level of the thyroid cartilage, as I showed you before. So this is a thyroid muscle right here, all of this. But the most medial aspect of the thyroid muscle is called the vocalis muscle, which is actually the true cord. The more lateral aspect makes up the paraglottic space and the glottic and the supraglottic larynx. Many people ask me, what would you use for imaging? Would you use CT or would you use MRI when it comes to the larynx? And usually I'm not partial to imaging, but I am definitely partial to CT for the larynx, because patients, they cough, they clear their throat, they swallow during scanning, and MRI a lot of times will be non-diagnostic. CT is super quick. You can scan the larynx from skull base to the carina in less than 60 seconds, and you can easily see all that you need to see for the larynx. If you have trouble evaluating for cartilage invasion, you can use dual energy CT, and we'll talk about that later. Also, MRI can also be used as backup when you have questions on CT for such as extralaryngeal spread, or if there's cartilage invasion, you can just do a focal MRI instead of a long study to help answer these questions that aren't answered on CT. So it's really important to understand plane of imaging when it comes to evaluating the larynx. When we do a routine CT, we don't use a scan angle, and we go from skull base to the carina. And you can see that the larynx itself is an oblique structure. So if you don't angle properly for the larynx, you're going to have supraglottic and glottic larynx in the same plane, and you're not going to be able to stage the patient or tell which subside is involved. So how do we fix this problem? Well, we do our irregular scanning, but then we take the raw data and we reconstruct the larynx portion of the scan in an oblique axial plane relative to the C45, C56 disc space, because that's in plane with the true cord and the false cord levels. So it doesn't matter whether you do CT or MRI, but you have to make sure that your axials are oblique axials. You can reconstruct after CT. On the MRI, you're just going to have to do your direct oblique axial imaging. Remember that PET imaging, you don't have angled imaging, so don't try to talk about subsites of the larynx involved on PET scan. So now I want to talk a little bit about pathways of tumor spread. It's important to understand that the majority of the tumors of the larynx are squamous cell carcinomas, so that's what I'm going to emphasize in this talk. But you can have submucosal tumors, with minor salivary gland origin tumors being the most common of the submucosal tumors. Far less common are sarcomas of the muscle and the cartilage framework, and even far less common are metastatic tumors. So remember, when you're talking about staging of laryngeal tumors, it only applies to squamous cell and minor salivary gland tumors. The sarcomas and metastatic tumors are not included in the staging system. So now we're going to talk about tumor spread patterns specific to the supraglottic larynx for squamous cell carcinoma. We break it down by looking at epiglottic tumors. We're going to look at suprahyoid epiglottic tumors, the free margin, versus the infrahyoid or fixed portion of the epiglottis. Then we'll talk about araepiglottic fold tumors, and then false cord and ventricle tumors. So review of adjacent anatomy. Here's the epiglottis. Here's the vallecula, base of tongue. Here we have the pharyngoepiglottic fold. So on CT, you can see the hyoid bone and the adjacent anatomy. Here is the vallecula and the piriform sinus and posterior pharyngeal wall of the hypopharynx. As you go more inferiorly on this MRI, you can nicely see the epiglottis and the pharyngoepiglottic fold, which makes contact with the lateral pharyngeal wall, posterior pharyngeal wall here of the hypopharynx, as well as the paired vallecula. Here on sagittal imaging, remember that the pre-epiglottic fat is black And if you're not sure if this black is infiltrated by tumor, look how nicely the pre-contrast sagittal T1 shows white fat. If it looks gray, then you know that there's tumor infiltration in the pre-epiglottic fat. Okay, so let's start with some tumor spread patterns. If a tumor starts along the suprahyoid portion of the epiglottis, so above the hyoid bone, this tumor is going to spread along the mucosa and it's going to make its way into the vallecula. Remember, we have the hyoepiglottic ligament that stops tumor from going in the pre-epiglottic fat. So all this tumor can do now is continue going anteriorly and north and make its way into the base of tongue. So here's an example of a real patient that had diffuse thickening. This is tumor involving the whole suprahyoid epiglottis. And you look more north and you look at the base of tongue and you've got too much soft tissue on the right. So what happened here is the tumor started on the suprahyoid epiglottis. It went into the vallecula and went into the base of tongue. You can see that the hyoepiglottic ligament is intact, so no tumor went into the white pre-epiglottic fat. So I just showed you a tumor that started on the suprahyoid epiglottis. Please don't confuse it with a primary tumor of the base of tongue. This is easy. You can see that there's a base of tongue tumor here. The bulk of the tumor is in the base of tongue, and it's exophytic into the vallecula, pushing the epiglottis posteriorly. So you're not going to confuse that with a laryngeal tumor. But be careful, because these tumors in the base of tongue can also go along the mucosa of the vallecula and make its way on the epiglottis, as you see here. Here's a primary tumor base of tongue, mucosally on the vallecula, and also on the ventral aspect of the epiglottis. This is a base of tongue tumor with epiglottic extension, not a primary tumor of the epiglottis. Okay, back to the suprahyoid epiglottic tumors. They can also extend laterally along the pharyngoepiglottic fold and make their way along the lateral pharyngeal wall. So here's an example of tumor in the epiglottis. You can see it's made its way on the AE fold. As you go more north, you can see that the whole suprahyoid epiglottis is abnormally thickened, especially the left side, and you see this bulky tumor making its way laterally. More cephalad, you see the infiltrated tumor of the suprahyoid epiglottis. You have air gap and you have tumor in the left lateral pharyngeal wall. Well, this can't be seen endoscopically, so we know that this is submucosal extent. And the way this happened was along the pharyngoepiglottic fold, made its way to the lateral pharyngeal wall. You must include this on your dictation because it can't be seen on endoscopy, and you need to report this so the patient is treated appropriately. Now, I just talked about tumors along the suprahyoid portion of the epiglottis, but now we're going to talk about tumors along the infrahyoid portion of the epiglottis, and they behave differently. And why is that? Well, that's because of the shape and just the anatomy of the epiglottis. More inferiorly, you can see it's more narrow, so tumor can go through more easily. But more importantly, you've got these fenestrations throughout the epiglottis. So if you have tumor, as you can see on this pathologic slide, that goes through a fenestration, it can go through and through into the pre-epiglottic fat. Remember, the hyoepiglottic ligament is going to stop it from going north into the base of tongue. So let's look at a real case. You can see this bulge here is tumor along the infrahyoid epiglottis. The suprahyoid epiglottis looks great. AE folds look nice. Piriform sinus, posterior pharyngeal wall, piriform sinus. The vallecula, base of tongue look amazing. Although you don't see the true cords coming together, trust me, they did. So this is considered an early tumor. There's no true cord paralysis. This tumor was thought on clinical examination to just be confined to the infrahyoid epiglottis. This is the same patient. They got a CT scan because the surgeon thought something just didn't seem right. Here we are at the level of the hyoid bone. I want to see some black fat at some point. Let's look at some normal anatomy. Here's the epiglottis, the vallecula, the pharyngoepiglottic fold, again, vallecula, epiglottis, pharyngoepiglottic fold. Here's piriform sinus. More inferiorly, we're about to finish with a hyoid bone. I have yet to see just pure black fat. I see this ball of gray. This is tumor and the pre-epiglottic fat. And as you look at the AE folds, they also are infiltrated with tumor. Remember that the AE folds were completely normal on the endoscopy, so this is all submucosal spread. Now, I see the paired arytenoid cartilages, but I don't see the high back of the cricoid cartilage, so I know I'm in the supraglottic larynx, not at the glottic larynx, because I need to see the cricoid cartilage too. So here we are seeing tumor in the false focal fold. I'm seeing dilatation of the left laryngeal ventricle. This is a laryngocele. On this CT, you can see the paired arytenoid cartilages on the high back of the cricoid cartilage. So now we're at the true cord level. You can see the muscle density of the true cord. There's no tumor at this level. So on endoscopy, this tumor looked like it was confined to the infrahyoid epiglottis, but in reality, on our imaging, it was far more extensive, and that needs to be known so the patient can be treated properly. I wanted to take a moment to describe appearance of tumors and their borders. I just showed you this tumor that had that was well defined and had pushing borders. This is a classic appearance for a minor salivary gland tumor that's submucosal in location, as opposed to what we normally see with squamous cell carcinoma that is an infiltrating tumor and tends to blow through soft tissues. So you can also have tumors that start along the false vocal fold or in the laryngeal ventricle itself. And when you have tumors that start there, you worry about going deep into the paraglottic space, because if it does that, like if this is in the supraglottic larynx, it can easily go into the glottic larynx, subglottic larynx, and extend anteriorly into the pre-epiglottic fat and not be seen on endoscopy. So here's a patient that has a left false chord tumor. It's well above the true chord. On phonation, the true chords come together, so there's no chord paralysis. This is considered an early tumor of a left false vocal fold. But if you look on this CT, you can see where the mucosal portion of the tumor is, but it's gone deep into the paraglottic space, abutting the cartilage, the thyroid cartilage. So this tumor now is in the paraglottic space of the supraglottic larynx. It can go into the pre-epiglottic fat, it can go into the subglottic larynx or the glottic larynx without detection on endoscopy. Again, it's our job to point this out. It's important to remember that with supraglottic tumors, that cartilage destruction and extralaryngeal spread is very rare unless the tumors are huge. So, and where can I confidently call cartilage invasion in any site? Well, if you see tumor on either side of the cartilage, you can see the strap muscle is abnormally infiltrated, is bigger than the opposite side, and you can see tumor within the larynx. This is definite cartilage invasion. So now I want to talk a little bit about the glottic and the subglottic larynx. So tumors, when they start on the glottic larynx, usually start on the true vocal fold, and they present early clinically because patients have a change in voice. Once you see these tumors on the true vocal fold, they grow horizontally early on, generally anteriorly, but can go posteriorly as well. So here's a patient. This is an endoscopy showing you that there's a tumor on this left vocal cord, and it's made its way to the anterior commissure, but you can see with phonation that the true chords come together. So this is an early tumor. There's no true chord paralysis. Let's review a little bit more anatomy, normal anatomy. This is CT. I'm showing you that there's cricoid cartilage and the pararetinoid cartilage is on top of it, so I know I'm at the glottic larynx level. You can actually see the vocal processes coming off the arytenoid cartilages too. You have muscle density of the true vocal cord or the thyroretinoid muscle. You have the anterior commissure and the posterior commissure where the mucosa is imperceptible. Notice that the thyroid cartilages have variable ossification, and that's normal, and these cartilages can ossify intermittently throughout life. This is an MRI, axial T1 pre-contrast, showing you the muscle density of the true cord, the thin mucosa of the anterior and posterior commissure, and you can see on pre-contrast T1 how the ossified portions of the cartilages are T1 hyperintense, and that can help you when you're evaluating cartilage invasion. So here's a patient with a left true cord tumor, and it hasn't even made its way to the anterior commissure. And on a clinical examination, the true chord's opposed, so it's considered an early tumor. So is this irregularity of the thyroid cartilage considered cartilage invasion? And the answer is no. And why is that? If you have an early lesion on the true cord, even if it goes to the anterior commissure and onto the opposite cord, as long as you have good cord mobility, what you're seeing on the thyroid cartilage, if it looks lytic or demineralized, is actually their baseline anatomy. When do we worry about cartilage invasion? When the tumor grows anteriorly, it's very bulky, it goes for a centimeter down into the subglottic larynx, and if they have a fixed cord, that's when I really know or worry that there might be cartilage invasion, but not in this scenario. So here's a patient with a right true cord lesion, and why am I showing you this? Because all patients that get neck CTs, particularly the larynx, but all of them should get scanned in quiet respiration, not breath hold. It's particularly important in the larynx for the very reason that I'm about to show you. In quiet respiration, the anterior and posterior commissure have imperceptible mucosa. You see nothing, right? So on phonation, as in this case, or in breath hold, The false vocal fold and the true vocal folds come together. That's expected. But you'll notice that there's bunching of soft tissue in the posterior commissure and the anterior commissure. And if you're scanning somebody with a tumor and they're holding their breath or phonating, you may overcall the tumor extension. Make sure the patients are scanned in quiet respiration, as was this patient who has a tumor of the left true vocal cord. You can see there's abnormal thickening of the anterior commissure, and it's actually going a little bit onto the right true cord. This is true tumor extension because they're in quiet respiration. So I've just told you that early invasion of cartilage on early lesions you don't see in the glottic larynx, but if there's always an exception to the rule. And that would be tumors that start in the anterior commissure of the glottic larynx. You can see that this early lesion has blown through. You can see it's lytic and the thyroid cartilage, and it's actually gone through and into the extralaryngeal soft tissues. So this is an exception to the rule. But what you normally see is when patients have a tumor of the true vocal cord, but the tumor grows horizontally first. Notice that we're at the level of the supraglottic larynx, because there's no cricoid cartilage here, but I'm showing you this because this tumor grew horizontally on the true cord, but then grew cephalad into the supraglottic larynx and inferiorly into the subglottic larynx, and over time, it's going to eventually go into the paraglottic. It's going to grow laterally. Notice that once you have tumor in the subglottic larynx, this tumor can move circumferentially because there's no barrier to tumor spread from one side to the other. So a little more normal anatomy. This is the subglottic larynx. Here's your cricoid cartilage. This is where you will have the cricothyroid membrane that you can't see. Notice that the mucosa of the subglottic larynx is imperceptible. Always scan your larynx cancer tumors with contrast. Notice that the mucosa here is imperceptible. Because we gave contrast, you can now see this minimal enhancing soft tissue in the right anterolateral subglottic larynx. This is subglottic extension of tumor that would have been missed had you not given contrast. Okay, I keep talking about cartilage invasion. And the early invasion of the cartilage is difficult to call. I just showed you lytic invasion. That was very obvious in the anterior commissure, but it's not uncommon for a tumor to go into a cartilage and cause sclerosis, or have adjacent tumor to a cartilage cause reactive sclerosis or perichondritis, and that's what the dilemma is. So when do we know a patient has cartilage invasion? Well, it's obvious when there's extralaryngeal spread. You know the cartilage has been invaded, so you can see the extralaryngeal spread here. You can also see that the strap muscle here is bigger than the opposite side, so you have tumor on either side of the cartilage. That's definite cartilage invasion, even though the cartilage looks fine. This is obvious. This is lytic expansile changes of the cartilage. You can see on soft tissue and bone window, so there's no question here. But if you think you may have early cartilage invasion, you can also get a dual energy CT to help you make up your mind whether you think it's true or not. So I pulled these images from a really nice article from Thorgani, Kelly, and Curtin, showing how you can use dual energy CT to evaluate for cartilage invasion. So this is an obvious case, but it makes a very good point. Here is dual energy CT, and the advantage of dual energy CT is you can evaluate the larynx at different energies that are going to point out different structures. So this is dual energy at 65 keV. This is similar to what we would see on a single energy CT at 120 kVp. So we see the tumor in the larynx, and we can see that the cartilage here is eroded. But if you're not sure, you can, on this image, you can see is a keV of 40. And when you go to a lower keV, the tumor pops out. The anatomy is not as pretty, but the tumor really stands out in contrast to what would be our normal single energy CT. But what I find particularly helpful is when you go to a higher keV, like 140, because at a higher keV, like 140, it causes iodine suppression. And what does that mean? Anything with iodine drops out. Look at the vessels, they've dropped out. Look at the cartilage. Cartilage is invaded by tumor, which is enhancing with iodine, and therefore it drops out. If it were just non-ossified cartilage, it would remain hyperdense. And finally, you can look at this iodine map. That it shows the quantitative iodine distribution, and what it does is it shows you the relative iodine content in the tissues. So you can see that the tumor here has high iodine content, as does the right thyroid cartilage, but as compared to the red non-infiltrated normal left thyroid cartilage. Okay, there How do we get extralaryngeal spread of tumor? Well, there are other routes. Remember I talked about the conus elasticus that goes from the medial cord to the inner aspect of the cricoid cartilage, that it directs tumors deep. And as tumors are directed deep and laterally, we have the cricothyroid membrane that stops tumors from going extralaryngeal. The best way to see that is on CT imaging, and I'm going to show you an example. So here's a patient, subglottic larynx. This is way too much soft tissue because remember the mucosa in the subglottic larynx is supposed to be imperceptible. This tumor is too thick and it's gone outside the cricothyroid membrane and into the prelaryngeal soft tissues. This is an example of a patient that had a left true vocal cord lesion. I'm showing you the supraglottic larynx. Notice the cricoid cartilage is not here, so I know I'm at the supraglottic larynx. The tumor has gone cephalized mucosally, but it's also gone in the paraglottic space of the supraglottic larynx. Here's the tumor where it started on the true cord. You can see it's blown through the thyroid cartilage and it's gone extralaryngeal at this point, but also it's gone subglottic across the cricothyroid membrane into the prelaryngeal soft tissues. I wanted to show you this really nice case that we often see. This is a patient that had lung cancer and they got their post-treatment PET scan well 3 months beyond their treatment. And this was read at an outside institution as a left true vocal cord tumor. This happens a lot. But I want you to look at the opposite side. Notice that the cord on the right is midline, has no FDG activity. You have laryngeal ventricle is dilated, as is the piriform sinus. And what we're seeing here is the problem is the right side. We have a right true vocal cord paralysis, and we're seeing normal FDG activity and a normal left true vocal cord. I want to compare it to this patient who had a oropharynx tumor, tonsil tumor. This is their post-treatment scan, 3 months post-treatment. And there was FDG activity not laterally but anteriorly in the larynx. Surgeon did an endoscopy and saw absolutely nothing. We presented it in tumor board, and they were saying, well, this is nothing to worry about. And I said, whoa, this is a PET CT. And remember that this is a low resolution scan that we use to do reconstructions of the PET. It's good for localizing, but it's not good for high resolution anatomy. I said, this doesn't make sense. Let's get a larynx CT. Got a larynx CT, and you can easily see that there's a subglottic tumor in the supraglottic tumor, in the paraglottic space. And because they couldn't see it on endoscopy, they couldn't biopsy it. So as radiologists, we did a nice FNA through the thyroid notch and proved that this was squamous cell carcinoma, second primary. So remember, it's not just FDG activity in the larynx that makes it the muscle, it's lateral position. So in summary, squamous cell carcinoma constitutes the majority of the malignant lesions. Non-squamous cell lesions are generally minor salivary gland in origin. They have pushing borders and are less aggressive in their features. And of course, understanding laryngeal anatomy is key to understanding tumor spread patterns.
Our last speaker of the session is Dr. Suresh Mukherjee, who is a clinical professor at Marian University and serves as Director of Head and Neck Radiology and ProScan Imaging and Regional Medical Director of Envision Physician Services. He also has been a past president of the American Society of Head and Neck Radiology, and he will be speaking on the hypopharynx.
My talk will be entitled Hypopharynx. I'd like to thank Alona for giving me the opportunity to talk on this area, and specifically the focus talk on the hypopharynx. Oftentimes, hypopharynx is lumped together with the larynx, and the larynx gets the full billing and the hypopharynx gets very little attention. So I think I appreciate the opportunity to really get into detail on this very important anatomy. These are my disclosures. And these are the people and organizations I would like to acknowledge, specifically Elsevier, Doug Phillips, Radiology Key, Nancy Fishbein, and Dr. Zhang. The areas that we'll be discussing include the technique, anatomy, neoplasms, infections, and congenital and developmental. I will not be talking about post-treatment, as there's a separate section of ASHNR specifically devoted to post-treatment. And the infections and the congenital lesions that I'll be talking about are specifically related to the hypopharynx. The primary modality that we use to evaluate patients with hypovaryngeal pathology tends to be CT. We all use multi-detector imaging. It's sub-millimeter thick sections. We reconstruct in general about 1.5 millimeters with overlap. We use contrast. I tend to prefer the dual phase technique with approximately 75 cc's of contrast, and we acquire our images with quiet respiration. And I think all of us are doing the nice reconstructions, and this sagittal images that demonstrates a very nice view of the posterior pharyngeal wall. CT is the primary modality for evaluation of patients with hypopharyngeal pathology, but there are other techniques that can be used. I found MR to be used mostly as problem solving, specifically if we're looking for more information if there's cartilage involvement or whether or not there's prevertebral space invasion, and we'll discuss this later. PET-CT is commonly used, and certainly in the practices that I work with, essentially anytime that we have a squamous cell carcinoma, the referring physicians, whether they're ENT surgeons or radiation oncologists, almost default to a PET-CT to look for occult lymph node metastases and distant metastases. And there is some work going on with PET-MR. This tends to be limited to academic institutions that have cancer centers. In general, it's not being used primarily. There is some nice work that's coming out of China regarding the ability of PET-MR to predict response. And I would refer you to this paper that's impressed by Zhang et al. Talking about some of the future directions with PET-MR. Well, so much about head and neck, and especially the hypopharynx, is anatomy. And what I'm going to do is spend a fair amount of time going over the anatomy of the hypopharynx. I tend to divide the hypopharynx into an external superstructure, the innervation, and then the internal anatomy. So the external superstructure is formed superiorly by the hyoid bone. Inferiorly, it's formed by the inferior border of the cricoid cartilage, and posteriorly, it's formed by the inferior constrictor muscle. Now, the superior pharyngeal constrictor muscle is typically, we're familiar with this because it's primarily involved in the oropharynx, but the inferior constrictor muscle forms the posterior border of the hypopharynx. The innervation of the hypopharynx primarily arises from two nerves. The motor innervation comes from the vagus nerve, and the sensory innervation comes from the combination of the glossopharyngeal nerve, cranial nerve 9, and the vagus nerve, cranial nerve 10, specifically the internal laryngeal branches. It's specifically important to understand this, especially in patients with otalgia. We think of patients that have otalgia with abnormalities involving the ear, the mastoid ear cells, the tonsils and nasopharynx, etc. But we always have to remember that the branches of 9 and 10 form the sensory innervation of the hypopharynx, and so therefore pathology that involves the mucosa of the hypopharynx can be referred to the ear, and you can have otalgia. So always keep that in the back of your mind. The internal anatomy of the hypopharynx is defined as follows. Superiorly, the hypopharynx is defined by this little fold of tissue that goes from the pharynx to the epiglottis. This is the pharyngoepiglottic fold. The pharyngoepiglottic fold defines the entrance into the hypopharynx, which is sometimes referred to as the introitus. The inferior border of the hypopharynx is formed by the cricoid cartilage. The anterior border of the hypopharynx is formed by this wall right here, which is referred to as the common party wall. And this term party wall is essentially used to define a wall that separates two different buildings or two different residencies, etc. So this separate party wall separates two different areas, the hypopharynx from the larynx. The posterior margin of the hypopharynx is formed by the inferior constrictor muscle. The medial wall of the hypopharynx is formed by the aryepiglottic fold. Now, in the larynx, the lateral border is the aryepiglottic fold, but the hypopharynx is the aryepiglottic fold. So again, the aryepiglottic fold, again, has a common border. And the lateral wall of the hypopharynx is formed by the lateral wall of the pharynx. So the hypopharynx has three primary subsites. These are the piriform sinus, the posterior wall, and the postcricoid region. And we're going to go over in great detail these specific areas. So the piriform sinus is a pear-shaped structure that it starts from the pharyngoepiglottic fold. Inferiorly, this pear gets narrower and narrower and eventually forms into a small little apex, which is referred to as the apex of the piriform sinus. So on the CT scan on the right, this is the most superior aspect of the pharyngoepiglottic fold. We can see the lateral aspect of the piriform sinus here. A little bit more inferiorly, we can see the aryepiglottic fold forming the medial wall of the piriform sinus. And on this non-contrast T1 weighted MR, we can see the hyson, the cricoid cartilage, the arytenoid cartilage, the cricoarytenoid joint. And right at the level of the cricoarytenoid joint is the apex of the piriform sinus, which corresponds with the little narrowing here, the tip of the pear, if you will. The posterior wall of the hypopharynx is formed by the inferior constrictor muscle. So on the left here is a schematic illustration, the diagram of the inferior constrictor muscle. Here's our diagram of the inferior constrictor muscle forming the posterior pharyngeal wall. This is our three-dimensional reconstruction, and on the axial images, here's our posterior pharyngeal wall here. Now, more inferior to it, we can see the tip of the arrow forming the posterior pharyngeal wall. This high signal here forms the lumen, and the posterior pharyngeal wall is typically very, very thin. Now, more inferiorly, there's a transition between the posterior pharyngeal wall and the opening of the esophagus, and this transition is referred to as the esophageal verge, and we'll have much more to say on this later. But the posterior pharyngeal wall eventually transitions into esophageal verge, and the esophageal verge eventually goes into the cervical esophagus, and the inferior border of the posterior pharyngeal wall is this muscle, which is the cricopharyngeus muscle. The postcricoid area is a very unique area that separates the hypopharynx from the larynx. And as I mentioned before, there's a common wall here that extends from the hypopharynx to the larynx that's referred to as the party wall. This specific area, this postcricoid area, in a way is almost, I would say, anti-gravity, because if you look at the posterior pharyngeal wall posteriorly, then you have the lumen, and then the anterior portion of the hypopharynx is this postcricoid region, and again, it's between this, separates this wall between the hypopharynx and the larynx. So when we look at the CT image here, right at the tip of my arrow, right behind the cricoid cartilage, is the postcricoid region. And at the cricoarytenoid joint, right where my arrow is, very, very thin line here, that is the common wall between the hypopharynx and the larynx, known as the postcricoid region. So what we've done so far is we've talked about the technique and the anatomy. Now let's talk about neoplasms. So essentially, any type of neoplasm that involves the upper air digestive tract can also involve the hypopharynx. So I've just included a few here: squamous cell carcinoma, lymphoma, minor salivary gland, sarcoma, or neurogenic. And the key thing here is that the majority of these neoplasms are going to be nonspecific. So I think any of us would be hard-pressed to separate this squamous cell carcinoma from this lymphoma. Here's a rhabdomyosarcoma. Here's a leiomyosarcoma. So a lot of these pathologies are nonspecific, and the referring physician can go down and biopsy these and come up with a differential, come up with a diagnosis. So they can see what we see. So our job is not to guess the tumor, but really to determine spread patterns. Another example here to emphasize this point: this is a squamous cell carcinoma. The middle area is candida, and without the history, you may can confuse this with squamous cell carcinoma. And on the right-hand side here is tuberculosis involving the piriform sinus. So even if it's an infectious process, these can also have a nonspecific appearance. So when we talk about hypopharyngeal carcinomas, they can comprise 7% of upper air digestive tract cancers. There's more common in males than in females. It's associated with Plummer-Vinson syndrome. The average age on onset is 65 years old. It is associated with tobacco and alcohol, and only approximately 10% of squamous cell carcinomas involving the hypopharynx are HPV positive. The subsite that's most commonly involved in the hypopharynx with cancer is the piriform sinus, followed by the posterior pharyngeal wall, and then eventually the postcricoid area. Now, this is some encouraging data from the SEER database indicating that the incidence of hypopharyngeal cancer is reducing. And this was an article published by Q et al. In the Laryngoscope in 2014 demonstrating a reduction in incidence. And this was an extension of this that was kindly calculated for me by Dr. Mustafa from Saudi Arabia, again demonstrating this decline in the incidence of hypopharyngeal carcinoma. And I would assume that this is due to diminished smoking and potentially reduced alcohol as well. So maybe a win for our public health services. So when we look at the hypopharyngeal carcinomas, as I mentioned before, the tumors tend to be very, very nonspecific. So our goal really is to identify information that's going to change how these patients are treated, and one of these has to do with the stage. So when we look at T1 to T3, T1 is less than 2, T2 is 2 to 4, and T3 is greater than 4. However, T1 is also limited to one site, and T2 is greater or equal to or greater than 2 subsites. So this is some of the information that we need to present on imaging. So as a result, we have to have a very good understanding where cancers arise in the hypopharynx. So this is an example of a hypopharyngeal carcinoma. This was a piriform sinus carcinoma involving the right piriform sinus. Notice how it's spreading along the posterior pharyngeal wall. And on the image of the right here, we can see an isolated tumor involving the mid portion of the piriform sinus. Now that's the mid portion of the piriform sinus. Remember I talked earlier that the piriform sinus has a little narrowing here that we refer to as the apex. The apex of the piriform sinus is easily seen because it's at the level of the cricoarytenoid joint. So if we're at the level of the cricoarytenoid joint, this is the level of the apex of the piriform sinus. And on the patient here on your right-hand side, this patient has a right-handed piriform sinus carcinoma involving the apex. Why is this important? Because if you have tumors that involve the apex of the piriform sinus, this increases the risk of level 6 metastases. And as a result, the surgeon, if the patient elects to be operated, must do a central neck dissection, or if the patient is treated with radiation therapy, they have to account for potential level 6 metastases. And again, we'll talk more about this later. The second subsite is the posterior pharyngeal wall. Here's a schematic illustration of a posterior pharyngeal wall carcinoma. And on the right-hand side, we can see this aggressive tumor involving the posterior pharyngeal wall on this contrast-enhanced T1 weighted image. The third subsite, as I mentioned before, is the postcricoid region. So the postcricoid, like I said, I consider this like anti-gravity. So the arrow right now is pointing at the posterior pharyngeal wall, and notice how this postcricoid carcinoma is arising from this common wall between the pharynx and the larynx. So in a way, it's non-dependent. It's not falling on the posterior pharyngeal wall. Rather, it's tacked to this common party wall. So it's actually anterior. So when we look at this image on the right, notice how the posterior pharyngeal wall of the pharynx is actually intact, and the involvement of the lumen is coming from superiorly from this postcricoid carcinoma, and you can actually see some subtle erosion of the cortex of the cartilage in this postcricoid carcinoma. So those are the 3 subsites. So in order to be effective for staging, we have to understand the subsites so we can properly determine whether or not these are T1 or T2 lesions. The next thing we have to determine is whether or not these other criteria are present. So these include things like laryngeal fixation, invasion of the cartilages, extension of the soft tissues, or involvement of the prevertebral fascia. And these are things that we can see easily on imaging. And if we see them, we need to comment on them. So here's an example of a patient that has a left-sided piriform sinus carcinoma. One thing we have to determine is whether or not this crosses midline, because if this does cross midline, then it's either going to be involving the posterior pharyngeal wall or the postcricoid area. So if this piriform sinus carcinoma crosses midline, it involves a second subsite, and this upstages this to a T2 lesion. Similarly, as we'll see later, if the tumor crosses midline, it's also going to change the potential primary echelon nodal drainage. Piriform sinus carcinomas that are lateralized are primarily going to drain ipsilaterally, but if we say these tumors cross midline, then all of a sudden the contralateral lymph nodes become at risk. The next area that we need to see is whether or not there's involvement in this area called the thyroarytenoid notch. So if you look at the anatomy of the hypopharynx, we can see that the posterior pharyngeal wall here attaches to the posterior lateral aspect of the thyroid cartilage. This acts as a natural barrier from these tumors extending directly laterally, and as a result, it redirects these tumors anteriorly between the thyroid cartilage and the arytenoid cartilage in this space called the thyroarytenoid notch. The end result is that there's tumor extending anteriorly into this paraglottic/paralaryngeal space. And on the right-hand side, again, we can see this piriform sinus carcinoma extending through the thyroarytenoid notch into the paraglottic space. And this can result in a cause of vocal cord fixation. The next thing we want to talk about is cartilage invasion. Now, we just had a lecture on larynx where we talked a lot about cartilage invasion. So it happens in the hypopharynx too. And again, it is not uncommon because, again, of this natural barrier where the inferior constrictor muscle attaches to the thyroid cartilage. So as a result, it can redirect the tumors anteriorly or laterally. So on the left-hand side here, we can see this piriform sinus carcinoma that erodes the inner cortex and a little bit of the outer cortex. And on this MR, this T2-weighted MR, we can see edema involving the posterior lateral lamina of the thyroid cartilage. And if we see this upstages these lesions to a T4A. The next thing we want to discuss is exolaryngeal spread. So here's an example of a piriform sinus carcinoma. Now, as I mentioned before, this inferior constrictor muscle and the attachment of the thyroid cartilage acts as a natural barrier. So these tend not to extend exolaryngeal and outside into the soft tissues posteriorly, but rather they tend to extend outside of the hypopharynx through this natural defect in the thyrohyoid membrane. There's a natural defect in the thyrohyoid membrane that allows a superior laryngeal neurovascular bundle to extend into the thyrohyoid membrane. This natural defect acts as an area of egress of tumors to extend outside, and this is an example of early exolaryngeal spread of a piriform sinus carcinoma extending through this small natural defect in the thyrohyoid membrane. This is oftentimes clinically occult, but does need to be mentioned. We also can determine whether or not there's invasion of the prevertebral fascia. Now, when I trained, unfortunately, in the last century, the way this was determined, it was by the surgeon performing endoscopy and literally tugging on the posterior pharyngeal wall. If the posterior pharyngeal wall was fixed, then this would indicate involvement of the prevertebral fascia. There have been some papers that have determined that if you perform T2-weighted MR and there's edema involving the prevertebral muscles, this is indicative of invasion of the prevertebral fascia. Now, I have to admit, I haven't done very many of these to specifically look for these. I know other centers do it. I still think that surgical assessment is important, but after talking with the surgeons, they do rely on MR. So if you are going to do it, then it's important to get axial and sagittal T2-weighted images to determine whether or not there is edema involving the prevertebral muscles. And if there is, this would upstage these lesions to T4B. So we've talked about various staging. We talked about involvement of one or two of the subsites, and we also talked about some of the criteria to determine whether or not there's T4A or T4B disease. But we also have to look at the ability to determine whether or not there's submucosal extension into the esophagus. And again, this is unique. Things like cartilage invasion or multiple subsite involvement can be seen in larynx cancers, etc. But the extension into the esophagus is unique for hypopharyngeal cancers. So let's go over the normal anatomy. So this was some anatomy right at the cricoarytenoid joint, and we can see the inferior constrictor muscle and the attachment to the thyroid cartilage. And I specifically want to call your appearance to the orientation and the morphology of the hypopharynx. It has a nice smile to it, as we see in this little emoji. So there's a smile right here of the hypopharynx, and there's the little emoji sign. As we come more inferiorly and we get to the base of the cricoid cartilage, we start to see a little bit of thickening, and instead of a nice flat smile like we see in this emoji, the smile gets to become a little bit thicker. And these little areas right here where we have these little pinch points right here that are starting to attach to the cricoid cartilage, this identifies the opening into the cervical esophagus. And this transition between the hypopharynx and the opening of the cervical esophagus is referred to as the esophageal verge. Then more inferiorly, on the right-hand side, we can see the normal appearance of the cervical esophagus, and based on our emoji, that's like the surprise emoji, right? So it looks just like a circle. So if you remember a nice thin smile, that's the normal hypopharynx. Once a smile starts to get bigger, that's the esophageal verge, and eventually it turns into a big O. So how do we use this clinically? Well, this is a patient that has a left-sided piriform sinus apex carcinoma, and when we look inferiorly, we can see that the cervical esophagus looks completely normal. So we can say there's no evidence of submucosal extension into the cervical esophagus. But in this particular case, we see a large hypopharyngeal carcinoma. When we look at the cervical esophagus, we can see it's markedly enlarged. So there is involvement of the cervical esophagus. Now, this was a case just from a couple weeks ago, a very large hypopharyngeal carcinoma. This was involvement of the esophageal verge, and we can see the verge is abnormal. And when we look at the cervical esophagus, there certainly appears to be tumor involved in the cervical esophagus. Now, one can say, now hold on for a second, this looks round, so what are some other things that we can look at to ensure and increase our confidence that we're looking at tumors? Well, first of all, we want to see whether it's round, and it is round, but when we look at the normal cervical esophagus, I want to point out the stripes here. We can see an area of low attenuation here, that's probably fat, we can see muscle, and then we can see the lumen. I've always referred to these as the tiger stripes. So in the normal appearance of the cervical esophagus, you should be able to see the tiger stripes. So the things that we look for to determine whether or not there's involvement of the cervical esophagus is whether or not the roundness has changed, whether or not there is diffuse thickening of the mucosa, and then thirdly, whether or not we can still see these nice little stripes right here. And those are the things that increase my confidence. So in this particular case, we were able to say there was at least 10 millimeters of involvement involving the cervical esophagus. So what about lymph nodes? The hypopharynx certainly metastasizes to the lymph nodes, and when you have lateralized hypopharyngeal carcinomas involved in the piriform sinus, they tend to metastasize ipsilaterally to levels 2 and level 3, as seen here on this PET CT. However, if you have tumors that tend to cross the midline, then all of a sudden both necks become at risk. In general, if it's far lateralized, contralateral lymph nodes are not at risk, but there is such a rich meshwork of lymphatics, and this is from Rouvier's paper nearly almost 100 years ago. You can see that if tumors cross the midline, it does involve the contralateral lymphatics, so therefore both lymphatic supplies both necks are at risk. So here's a metastases on the right, and here's a metastases on the left. And again, underscores the importance for us as radiologists to mention whether or not these tumors cross the midline, because it does put the contralateral neck at risk. The other area that we have to mention, I mentioned this earlier, was that if we have a tumor involving the apex of the piriform sinus, these tumors place the level 6 lymph nodes at risk. So again, from Rouvier's paper, we can see here's the apex of the piriform sinus, and now we can see lymphatics that are directly have primary echelon drainage to these paratracheal level 6 lymph nodes. So in this case, a piriform sinus carcinoma with a positive level 6 lymph node, and on the right-hand side, a PET MR of a hypopharyngeal carcinoma that's involving the base of the cricoid cartilage, and again, we can see a level 6 lymph node at risk. So things that we always have to look at. We always have to look at all the lymph nodes, but our vigilance has to be heightened as we specifically look at those tumors that involve the inferior portion of the hypopharynx. The other lymph node group that we may forget about are the retropharyngeal lymph nodes. So the hypopharynx and the piriform sinus is a long ways away from the skull base, but there are primary echelon lymphatics that go to the retropharyngeal lymph nodes. So anytime we look at piriform sinus carcinomas, we have to look at the skull base, and in this case, we can see a small little metastatic retropharyngeal lymph nodes. Now, I have been to several talks where people talk about, wow, this patient had a treated piriform sinus carcinoma and then developed a synchronous nasopharyngeal carcinoma. Well, that was probably due to a metastatic retropharyngeal lymph node that was not detected and was never treated. Well, we'll then move on to infections, and we're just going to spend a little bit about time on infections specifically involving the region of the hypopharynx. And you've all seen cases of retropharyngeal space abscesses. I specifically want to put this in the context of the hypopharynx. So number one, when I look at retropharyngeal abscesses, one thing I've learned is that unlike abscesses in the liver or the brain, these tend not to have an enhancing wall. They just tend to be large fluid collections that expand the retropharyngeal space, that are non-enhancing in patients that are febrile and obviously very sick. So the enhancing wall, I've seen many people say, well, it can't be an abscess because it's not enhancing. Well, just realize in this area, you don't have to have enhancement. There are several causes of abscesses involving the retropharyngeal space as associated with the hypopharynx. This was a patient that had a retropharyngeal space abscess from a nasogastric tube perforation. This patient, unfortunately, had the classic plastic fork break off and pierce the hypopharynx, causing an abscess. This patient had a retropharyngeal space abscess from a post-cricoid carcinoma perforation, and this patient had a retropharyngeal space abscess from a posterior pharyngeal wall fistula. So these are all causes of retropharyngeal space abscesses from primarily hypopharyngeal pathology. We have to remember, too, that once we get back into this high rent area behind the inferior constrictor muscle, there's two specific spaces. The area here in purple is the danger space that extends from the visceral fascia to the alar fascia, and then in orange here is the danger space that extends from the alar fascia to the prevertebral fascia. So the true retropharyngeal space is in purple. This ends at approximately T2 to T6. And the orange space here, which is a danger space, extends into the mediastinum. So the bottom line is that anytime that you have an abscess involving the retropharyngeal space, we always have to include our imaging down into the mediastinum to make sure that we don't have a clinically occult mediastinitis, because this is how these tumors spread. So this was a patient that had recurrent thyroiditis. Now, I put this in the infection category because there is a pathology that can cause recurrent thyroiditis. Now, once this patient was treated, we saw a small little area of air right here. And this little area of air is due to a fistula from the piriform sinus that communicates with the thyroid gland. And so we're now going to change to congenital and developmental lesions, because this leads us into the discussion of branchial cleft anomalies. So the third and the fourth branchial cleft anomalies both have fistulas that involve the apex of the piriform sinus. The third branchial cleft anomaly has its fistula that extends superiorly, and it parallels the superior laryngeal nerve and then descends in the posterior triangle of the neck. The fourth branchial cleft anomaly extends from the apex of the piriform sinus directly inferiorly. So the case that I showed before should be a fourth branchial cleft anomaly. Now, the challenge is this. These fistulas are more common than we think they are. So oftentimes we see something like this in the child and we call it a lymphatic malformation. Well, I've had several cases where this has been resected and it's turned out to be a third branchial cleft anomaly. Similarly, these little fistulas that extend from the piriform sinus into the thyroid gland, these are the fourth branchial cleft anomalies. And it's important that we, the radiologists, understand the difference. Because when the pathologist looks at this, all they see is that they see pathology consistent with a branchial cleft anomaly. That's all they can say. When the surgeons look down, they see the fistula. So they think, well, yeah, there's probably a branchial cleft anomaly here because there's a fistula involving the piriform sinus. But it's really us as the radiology to map the specific location. So if we see something in this location, in the posterior triangle, and the pathology comes back as we see here, this is a third, we can say that. And the case inferiorly, we can see this air extending into the superior aspect of the thyroid gland. We can then say definitively that this is a fourth branchial cleft anomaly. So I would argue that it's really up to us as a radiologist to make the specific diagnosis as to the specific embryologic cause of the branchial cleft anomaly. And the last area that I'll talk about is a developmental abnormality, and this is the classic Zenker's diverticulum. Zenker's diverticulum is caused by uncoordinated hypopharyngeal contraction against the dysfunctional cricopharyngeus muscle. So typically when we swallow, we have these swallowing waves that involve the inferior constrictor muscle that are continuous with opening and closing of the cricopharyngeus muscle. If there is uncoordinated contraction, the cricopharyngeus muscle does not relax but continues to be constricted. There is a small little defect here between the inferior pharyngeal constrictor muscle and the cricopharyngeal muscle. This is called Killian's dehiscence. So you can see is that the inferior constrictor muscle is pushing the food down and the cricopharyngeus muscle does not relax. You can end up developing a pulsation diverticulum through this natural defect. And this is what's referred to as Killian's dehiscence. So this is an early pulsion diverticulum, and this is the more advanced pulsion diverticulum. So how do they look on imaging? This is the days when I used to do barium swallows. This was a cricopharyngeus muscle that did not relax. And you can see superiorly to it, we can see the Zenker's diverticulum extending posteriorly along the cricopharyngeus muscle. This was a Zenker's diverticulum that was oral contrast, and we can see contrast in the Zenker's diverticulum. And on axial images, we can see oral contrast within this diverticulum. Now, you can look at this and say, wow, it sure as heck looks like an abscess, but realize you have to put everything in the clinical context. And in this particular case, the patient had no fever. They had signs of difficulty swallowing and reflux. So as a result, we can make the diagnosis and feel very comfortable that we're dealing with the Zenker's diverticulum. So in summary, over the last 30 minutes, we've talked about technique, anatomy, neoplasms, infections, and congenital and development anomalies involving the hypopharynx. Thank you very much for your attention.